Once upon a time, life used to be a Puritan process, and medicine used to be the science and art of healing. The medical profession was meant only for the few blessed ones, people with a passion to heal, working to earn something priceless, good karma.
Good morning. So, ladies and gentlemen, it is my pleasure to open the second session this morning in this room too. Let me introduce you the persons that you see. So, Dr. Pravin Chandra from Delhi, India, myself, Leo Finci, and Dr. Marko Noć from Ljubljana. We have also a panelist, Aleksandar Aleksić from Belgrade, Jelimir Antonić also from Belgrade, Miroslav Bikitski from Novi Sad, Valery Gelev from Sofia, Nikola Jagić from Belgrade, Sasha Lončar from Banja Luka is not here, and Nebojša Nikšković from Belgrade. So we will have the live transmission, and let me introduce Dr. Shri Hiremath from Pune, India, who is already on the screen.
Okay, so the right. Hi, good afternoon, everybody. It's our pleasure to be transmitting today to you all in Serbia. I guess it's a pleasant morning for you people, pretty warm Europe this year. And we are post-lunch. We are around 2:30 p.m. In Pune. Pune, we are about 3 hours drive from Mumbai, and Ruby Hall is a big cardiac place. We've been sort of front runner in the country for last about 30 odd years. So today for you we have, can I have the first slide? Something interesting. This is a 65-year-old gentleman. Just check the pen. He's diabetic and hypertensive. He had a previous PTCA to circumflex ostium about 6 years back. And he has now low threshold angina for last 1 month. So this is how the story is. And we come back to today's images. Can we have the first run here? To introduce my colleagues, we have Dr. Makhale with me, and Dr. Gaurav here, and Rachel is prolific with us, and Joel, he would be handling the machine, and Mayur you can't see, but he would be with us for OCT and other requirement. So you are able to see the first run of today's angiogram. So as I told you, circumflex as a stent in the ostium. The distal part of the stent certainly looks good, but we leave it to your wisdom to make decisions.
I don't see the angio. Can you adjust?
Okay. All right.
Ujjwal, can we go to the angio?
Live, fluoro live.
Fluoro live.
Yeah, that's perfect.
So we have now you're with us. Yes, I guess you're with us.
Yes, Dr. Makhale, I'm Pravin Chandra here.
Hi, how are you?
And so, no problem, don't worry.
Okay. Are you able to see the live fluoro there now?
So we have...
Yes, I can see that. Fine. Yeah, we can see the live fluoro, and everything is okay. Good. So go ahead.
The transmission is good. Thank you.
This is a areocaudal, as you can see. Circumflex has an ostial stent. The distal part looks good. And we'll make some decisions about the ostial portion of the circumflex. Next view. And in this view, we are able to see left main distality clearly narrowed. The LAD ostium also is significantly narrowed. And the circumflex mouth plus minus, probably more yes than no. So you can make your observation. I will show you the epicranial view, and the distal portion of the LAD looks good. So we have, can you come back to spider view and freeze this? Go step by step. Can you zoom? And this is the image for you. Just go step by step forward and backward. So this is a 6-year-old stent in the circumflex. So Dr. Marco and Dr. Leo and Praveen, can we borrow your wisdom as to how you would like to do the case?
Okay, so we have this image very clear here, and we have Dr. Marco. Can you, what do you think? Should we go ahead straight away, or we need to do some evaluation?
I think, you know, we have Medina 1-1 case left main. It's obvious. My question is about the circumflex stent. Is that really an ostial in-stent stenosis, or maybe migration of the stent from the ostium such the ostium is not covered? Maybe if you can do IOS, you could get that answer. But you know, it probably will not influence much your strategy. And I would like you to comment what's your plan, what's your strategy for that distal left main PCR?
Sure, I think
Yes, I think also you can do without imaging, but it would be very good to have some kind of intravascular image, IVUS or OCT, whatever.
Okay.
So basically, you know, what we have here, Dr. Hiremath, is that the question is whether the stent is at the ostium or not, because it appears from the images that probably the stent is just beyond the ostium of the circumflex, because then the strategy will be slightly different compared to if the stent was in the distal part of the left main and covering the ostium of the circumflex. So, you know, it appears that definitely these two lesions are significant. The circ is not looking so tight, but at least it is looking like 60%. Yeah. So tell us, what is your plan?
So we thought we'll image the patient with an OCT. So we'll run the run number 1 on OCT from circumflex to...
Ujjwal, show OCT on a main screen and fluoro on a small left.
So first OCT is from, can we run? From distality of the circumflex.
Let OCT be big. In hemodynamics, you can get a fluoro.
So I think a part of the stent is well covered by endothelium, and part of the struts are still a little bit exposed, but well opposed stent.
More or less okay.
Yeah, but can you go back to around 32? So this is the area where we feel you can see not the stent fly through. Can you make it big, a big screen, not the fly through, but the other one?
No, remove the fly through.
No, the other one. Yes.
No, make it full.
So we'll show this to you again. All right, run from there. Don't run the distal part.
Right,
Not necessary. Okay.
20,
Huh.
So stent is well embedded. There is some NIH.
Oh, freeze this. Gaurav, any comments here?
So angiographically, it appeared that the LCX ostium is well covered with the stent, and the lesion at the ostium of LCX was appearing more or less around 50%, not more than that. but then this OCT run clearly says that it is more than NIH. It is not only NIH.
Go back,
There is fibrofatty
one
plaque
frame,
inside
one
the
frame,
stent,
one frame. Proximal.
and that
Yeah.
creates significant stenosis at the
Yeah,
LCX
stop there.
ostium.
Mm-hmm.
So now it appears like a Medina 111, distal LMCA, osteal LAD, and osteal LCX disease. So I think whatever strategy we decide, we have to take into consideration Medina 111.
We will now show you the run.
Just
in-
wait, I
So
want,
is
I
the
want,
stent protruding into the left main?
yeah,
Yeah,
if you
we
see
can't
the
make it out
image,
very clearly.
if you see the image on the screen right now, you can see those white dots where
Yeah.
it is actually at the ostium, and it is one of the strut is protruding towards LAD ostium. So the stent position looks good here, no question about it.
It's a bang
It's
ostial
a bang ostial,
position.
although the
Let's run the LAD.
radiologically we are not too sure. Okay, we'll show you LAD run also. We have done LAD run.
Perfect.
So actually our original plan was to put a stent from, okay, let's see the LAD run.
We come near 22, 23.
So it's critically narrowed.
Yeah.
Yeah,
And you can see the circumflex mouth coming up at 11 o'clock.
come
just
back.
Come back a little bit.
Some more, some more, some more, some more. See, some more.
Keep coming back slowly. So this is left main. Keep coming back, back, back. So that's proximal
Shaft of the
mid shaft of left main and proximal portion of left main. I think that looks reasonably clean. All right, should we go back to the angio imaging?
Yes, yes.
Okay, can we
So with
go
this
back to
OCT,
angio? Yes.
the information is very clear that the stent is coming up to the ostium. Although here it was appearing that probably the ostium was missed in the first implantation, but it is clear. So OCT, the value of OCT here is that we know exactly what it is inside and what are we dealing with. Because these days, I mean, if we have a situation like 001, the recommendation is to put the stent from the left main to the circumflex. So now it is clear that the stent is right from the ostium, and we have reasonable space to enter into the LAD.
Yeah.
Yes,
So
so,
So
sorry,
now it
go ahead.
practically becomes a 111 actually.
So now it becomes a 111. So it has turned from 001 to 111, right?
Cutting balloon ready.
So what strategy would like to plan? 2 stents obviously.
Cutting balloon.
Yes.
Okay.
Yes.
And
3.5.
what the usual discussion? What type of other strategy you want to do? The just for the discussion, whether you want the DK crush, culotte, or tap, or what? What's your
So
opinion
let me, ask, there are interventional cardiologists sitting here in the audience. So how many people feel that it is a 2-stent strategy? And how many feel that it is just 1 stent and provisional? So one person has, given this opinion of 1 stent strategy, but most of the crowd sitting here says 2-stent strategy.
I think we are pretty much in line
So
with
any
two
reason
stent
why you say
strategy.
this?
Yes, can you repeat? They did not hear there.
Yes.
There is around 20% restenosis rate if you stent the stented segment.
Mm-hmm.
And especially at the osteal circumflex, that is a paradigm of interventional cardiology. You already have a stent there. Why don't you just use a balloon and maybe drug coating balloon?
NC balloon level.
For the same result.
Then we'll take cutting.
So that means you are saying that 1 stent from the left main to the LAD and a drug-eluting balloon to the circumflex ostium. Perfect. I mean, this sounds very good. This is a good idea. And many of us have done this kind of approach a couple of times, but I think you have reason in doing this. But most of the people sitting here say two-stent strategy start to go, from the very beginning. So now the second question is, which two-stent strategy? So how many people feel that it is a provisional stent? Cap technique?
First time, 6 years ago, was it acute myocardial infarction for the circumflex? Was it acute myocardial infarction?
Okay.
If it was, maybe it is not significant stenosis. Maybe we should do FFR for L6.
Okay. So here again, a very, very practical point has come up that if the circumflex is already infarcted or it was a previous acute MI and we feel that this territory is not so important, we just
Praveen,
from
the LV ejection fraction is 50% on echo. The contractility in the entire area is pretty good, though inferior wall is mildly hypokinetic. But
So
there
we have to
every
respect-
reason to believe that that portion is very viable. So I would strongly feel that it needs to be revascularized. So we think we would do culottes here. I strongly believe that we should not be missing any or any of the area metal-wise. So only two strategies come to my mind. One is DK crush and second is culottes. Mini crush can be an option, but there is already a stent there, so recrossing may at times be very difficult. So if you want to end up with a good final case, DK crush would be a good important strategy. But I would rather prefer culottes because that would give a very good metal coverage in this area. So at this stage, I feel I leave the live and we go to some of the similar cases quickly, one slide each. You can work. Can we go to the slide, Abhijit? Next slide. So these are actually single stent in left main area, presenting late with left main area restenosis. This is from our shelf. Next slide. So you can see on the left top, this was a stent in the ostial LAD. I've drawn it in red diagram on the top. The stent is projecting back into the circumflex mouth, and patient came back 8 months later with critical angina. And you can see in eleocranial movie run that the circumflex mouth is showing critical disease. And this is what we have done. In the middle portion, you can see the the blue wire is actually passed away from the back end of the stent. You have to be quite careful in pushing this wire properly. You can take a help of stent boost while pushing a wire like this. You crush the stent, and you can see in the top right corner two stents located. The green one is the new stent, the red one is the old stent, and we end up with T kind of stenting, more like mini crush because the back end of the stent had to be crushed, and this result was perfectly achieved. So this is a mini crush technique that we have used for a stent which is projecting back into the ostium. Second slide. In this particular case, the stent is placed in the circumflex mouth, exactly what we have in today's case. So the stent was actually projecting into the left main, and this was seen on the OCT. So we decided to pick up the back end of the stent, press it against the roof of the left main, and that's why we ended up with a mini crush. So the second stent is now going from left main to LAD, picking up the back end of the first stent deployed. So this is how a mini culotte was done to get a perfect result. And the next case. And in this case, the left main to LAD stent was placed about 14 months back. The operator felt he need not address the circumflex, and that too dominant circumflex. Patient came back with critical angina at the ostium, as you can see here. We had to really think what you're going to do. We have one stent placed, and then we decided we will put a stent in the circumflex ostium. Next slide. We did an IVUS, of course, and it indicated that the circumflex stent was not fully expanded. So we needed to put 2 stents. Can you show the next slide? So see, you have 2 stents. One is the old one, as written there, 2016, and the new stent is now going from left main to circumflex. Then you do a pot, and then you did an FFR on the LAD area, which was positive. Next slide. And then we bring in another stent. So we are actually doing a culotte today, but there is already an existing stent, so it's like double culotte with the earlier stent to get a final result which looked very good. Whenever you have instant restenosis in this area, you have to really think what kind of strategy is going to work. So can we all leave you here? I believe you want to have some presentations, and we'll come back to you with some steps.
Thank you very much for these case-in-case presentations. Okay, can you tell us a little bit what you have done and where are you now?
Runs. So we will just take you with us. As we were talking, patient had severe angina, became unstable, and the QRS was getting broad. We thought we may have to intubate, it was that severe with gross ST changes. Jump quickly. So we had Jump come to wiring. 1 minute. So the original plan was to do a culottes, first stent in the circumflex, second in the LAD. But at this stage, when we were doing this, the LAD flow was heavily compromised, extreme clinical instability. Gaurav, you want to tell them what we did next?
So we changed our mind, and we had to change the steps. We had to tackle the LAD first, since patient had severe angina, hypotension, and significant ECG changes. So even though we had dilated LMCA to LCX with 3.5 millimeter of balloon, we had to tackle LMCA to LAD first. So we prepared bed for LAD with same balloon, 3.5 into 8, 3.5 millimeter balloon, NC balloon with high pressure. And we had to immediately stent the patient from LMCA to LAD. And you can see here the stent
going fast.
The stent from LMCA to LAD. So this is 4 into 26 millimeter onyx stent.
Okay, 1 minute, Gaurav.
Wait. See, this is a stage where the patient became unstable. He had a QRS widening, hypotension, restlessness. We were about to intubate. And if you can still see here, the circumflex is patent. Continue to run, that's all.
Same run.
And although the standard rule is that we should not touch the LAD here at this stage, we had no option but to address the LAD, because ladies and LAD are to be respected more. Next run.
So as I would like to re-emphasize, the original plan was stent circumflex first. So we had done balloon dilatation to the circumflex. Because of heavy clinical instability, we are switching the plan and planning to stent the LAD. Makhale?
So now we have got this LAD stent here. This is a onyx 4 into 26 millimeter. We chose the reference diameter to the proximal left main.
And the diameter was matching the distality of LAD, which was around 3.8. So we chose 4.0.
Okay.
The
and
onyx.
at this stage, we remove the guide wire from the circumflex. That requires a lot of luck also, because we know that this LCX ostium has been dilated, but we had no option to address the LAD at this stage.
Actually, two can argue whether to remove the circumflex wire or no at this stage, but the only intention of removing it was 2 layers of metal which is already there. The wire can be heavily trapped and sometimes very difficult to remove. So taking a little bit of chance, we said we'll remove the wire. The LED stent is in position. We are keeping 8 millimeter length proximal to the origin of the circumflex. That's the pot balloon size that we have.
So here we are deploying the stent.
I think there can be a discussion whether at that point of time we should change from culottes to decay crush, because we can prepare bed in both LAD and LCX if we consider decay crush. So anybody who would agree with me for decay crush?
Okay, any comment from the panel or from the audience at this point?
Maybe one question. What's the reason for this hemodynamic instability? Because there's also LAD TIMI2 flow. What happened? Do you have any explanation? Because at the beginning the patient was very stable. I understand.
Actually, we had done a balloon dilatation from left main to circumflex. I think it's more the left main dilatation which actually compromised the flow in the LAD. We had a wire in LAD though.
Okay.
So this I think is the explanation why.
Another thing is even if you see the OCT images, the diameter area there was about 1.26, and even the OCT catheter when it was across into the LAD, he did have angina, but it was for a short duration. We took a OCT reading and came out, and that's what it was stable. Now here, after dilatation of this left main to the circumflex, patient really became unstable with a QRS widening, and he was restless, and saturations were dropping. So obviously he was going into the left ventricular failure. So we had no option but to address the LAD earlier.
I think, that was a very, very wise thing to do, because the most important thing is the hemodynamics always have to be taken into, consideration. And then changing the plans is absolutely reasonable. And as far as taking out the wire was concerned, again, that was a very good idea, because as Dr. Hiremath said already, that crushing the wire between the two metal layers will be very difficult to take it out.
We have also a comment from the audience, please.
Now the patient is stable. Is the patient stable now?
Yeah,
the hemodynamic?
you can looking at our faces,
as
you
we
can
are
make
talking,
out.
he is very stable. Yes. So we have deployed the stent left main to LAD 426. We are doing a pot with 4.5 balloon. You can see here the metal to old metal stent contact is pretty good. That means the old stent is deployed pretty well. You could stent it very nicely on the stent boost. Unfortunately, we are not in a position to show the stent boost to you. No, it will not be possible. But trust our eyes and brains that the stent are making a good contact. So we do a pot with a high pressure 4.5 dilatation. We seem to have good flows in both the vessel, hemodynamic steady, and now we are in a good position to come in with another wire. Next. So this is a fluoro zoom we use many times. This is a FD20 that we are using. We actually like to go to the distality into LAD, come back, and while coming back, push in the wire. But since we were trying to wire quickly, accepted whatever was coming. At this stage, we decide to do the post-dilatation to the deployed LAD stent. So this is a non-compliant balloon doing high pressure inflations on the entire length of the left main LAD stent. So we have 2 wires going through the correct lumen. Next. And then we bring in a 2O balloon to the circumflex. The balloon went in quite easily. We have done some pre-dilatation with 2O balloon, and now we have a 3O NC to sort of expand the stent strut going towards the circumflex. So this is where we are. We could have your comment as we keep working on this.
I think you did very well. I mean, you saved the hemodynamic situation. You have a very good result in the LAD, and you changed the strategy appropriately according to the situation of the patient. I think now it's time maybe to consider what was suggested by the panel, with one of the panelists, to use a drug-eluting balloon for the circ and skip another stent stent because you already have one layer in the circ. You have OCT clearly showing that the persistent restenosis and the stent was really touching into going into the left main. So what do you think about changing your strategy now to single stent plus drug-eluting balloon in the circ?
All right. You want us to do OCT at this stage on the circumflex?
I mean, the point he raised here is, Dr. Hiremath,
Drug balloon.
that once you are doing this dilatation to the ostium of the circ, it is also better that we have the balloon in the LAD and we do a kissing at the same time, because otherwise you will crush the LAD stent quite badly. Number one, and number two, you can finish off
at this stage.
case.
The first balloon was 2.0, which was just for opening.
But at the time of 3 millimeter
3.0
balloon,
we were just around 2 or 3. We have not gone high on pressure. If you go high on pressure with a single balloon like this, you can bring down the stent, deployed stent, from the roof of left main LAD down, which is not a nice thing, and that's why kissing is strongly required. We are just making a space for the stent to go through, nothing more.
Okay, so what do you think about this drug-eluting balloon concept? Because putting a DEB in the circ and now finishing off with a kissing balloon after the DEB may also do the job. Because otherwise you will have 3 layers of stent in the proximal part.
I would rather put a stent, and I don't think I'm a great believer of DEB at this particular location, because circumflex ostium is one area where we always worry. In fact, we did a cutting balloon dilatation to the circumflex mouth today because the reach narrowing chance is extremely high. However, on OCT today, we find the stent expansion is quite good. It's just the neointimal hyperplasia which is producing the narrowing. So if somebody opts for DEB, I think I would respect his decision, though personally we would go in with another stent.
Unfortunately, the drug-eluting balloon what we have available here is sirolimus eluting balloon, and the previous stent was also sirolimus eluting stent. So it's better to change the drug.
15.
And unfortunately, we don't have any other drug-eluting balloon available here. So I feel that we should go ahead with everolimus or zotrolimus eluting stent in LMCA to LCX location.
Perfect.
Okay, there was a comment
you are
from
doing is
the
absolutely right. And so as we discussed, there are so many ways of treating a complex situation.
Okay, please ask your question.
Hello, Dr. Sashko Nikolov from Macedonia. As you perfectly managed to stabilize the patient hemodynamically, but when you put the stent from the left main to the LAD, you choose on purpose to left the ostium of the left main, or that was because of the sizing of the stent? And now if you go for the second stent strategy, would you prefer to cover the ostium of the left main?
Left main ostium is quite good actually. We don't
Yes,
want to
on OCT, the left main ostium is quite good. The second issue is the diameter of the circumflex is just under 3. And to get a 3.0 stent up to a very high diameter is probably not easy. Though we are using, of course, both stents are onyx, and you know onyx has a sinusoidal design which allows the stent to go up. 3 can go to 3.75, 4.0 can go to very high diameter, something like 5.5. So this particular stent we have chosen is 3.5. So I would probably not, I mean, we have made sure that we are not dilating the ostium with the balloon. So at this stage, the stent looks in good position. We'll be taking a stent boost. Should we remove the LED wire?
No, right, like it. We'll do it afterwards.
Stent boost. Remove the LED wire.
Yeah. Now
I think we should remove the LED
Let's remove the LED wire.
So on stand boost, we look in good position. I'm removing the LED wire. So I take another stand boost.
LED wire काटते हैं बस.
So I think we are trying to
So
keep
you're going
the
back to the culotte. Yeah.
yeah, it's a culotte, but it's a reverse culotte where we are keeping the length of the inner stand very short, as much just to keep the two layer stand minimum in the left main.
What do you think about tap technique in this case?
We discussed tap technique. Get me 4.5 balloon. On tap, the metal to metal contact is desired. I mean, of course, if you do a good tap, you're making a good connect. But the kind of stability or assurance that you get out of culottes probably is not there with taps. So though culottes is a little bit more labor intense, you can go very high on pressures, high pressure deployment subsequently, and so on. So I would probably prefer doing culottes or decay crush and not tap in this case.
इसका प्रोफाइल रिड्यूस नहीं करें. ये मोटा हो गया.
What we feel is with culottes, probably both Ostia as well as the Neo Carina, both are very well covered with enough layer of metal. So in a case where there is always a doubt whether the first stent, the old stent of LCX was projecting into the LMCA or whether it was covering only the LCX ostium, so it is better to have proper coverage of both Ostia as well as Neo Carina.
Yeah, so your logic is okay, but as we are discussing, there are so many ways of going ahead, and doing a tap may also be a good idea because the steps will be simpler, and you already have done the stent on the left main. So anyway, so you keep working on this.
Okay, do you hear us?
Yes.
Yeah.
Yes, we are with you again. Makhale?
Yeah. So we have deployed the stent in the LED, and we have crossed across into the circumflex. We dilated the mouth of the circumflex, and after that we brought Onyx 3.5 by 15 into the circumflex. The transition was very easy. Now here we have deployed this stent into the left main to the circumflex.
Freeze.
A part of, and we have purposefully removed the wire from the LED.
You can also make out the original stent is on the back side in the left main, while the second stent is a little bit further. So overlap is about 2 to 3 millimeters in culottes in this case.
Yeah, we can see.
Yeah.
Next run.
Play.
So we of course check this on stand boost, make sure everything is in correct position, no wire in LED, inflate, deploy, then this is a pot with 4.5 balloon. Next.
Then we recrossed LED.
Pretty easy actually. Next.
Opened the strut with
3.5 balloon.
no, initially 2 followed by the 3.
2.0 and 3.5. Next.
2 is not recorded. Next.
Then this is opening the strut towards the LED with a 2.0 balloon. And now we are
preparing for the
final case.
So our one balloon is already the circumflex. This is a 3 into 8, and we are getting another balloon into the LED, 3.5 by 12.
All of you believe in doing a repot or not necessary?
Hello, are you with us?
Yes, of course, we are listening what you are saying.
Yeah,
we were discussing between us how good it is to change the strategy, from one to the other one. So we are thankful that you keep it as simple as possible.
You control.
Yeah.
You control.
So we have a 3.5 in LED and 3.0 in circumflex.
M14.
Go up 12,
So we keep
14,
one
16, 20. Go to
LED
4.
stand, LED balloon at low pressure went
going
all
to
the way to
16.
28 on the other one.
18.
We come
20,
down on the LED
22.
and go
Go to
high on
4.
circumflex. So it's a differential
4 to
pressure and
6,
end up with good
8,
pressures, something
10,
like 12,
12,
in each vessel.
14.
So this is 12 in each, 14 in each.
Yeah, now we are 16 each. And
So we'll take a stand boost.
Can I just ask, you selected 3.5 for the circ, but now the balloon is 3.0 for the kissing.
Yeah, because we wanted to use the sum of the two, that is 3A plus 3.5 will be the 6.5, and the point of contact will be the 4.5 when we are doing the bifurcation kissing technique.
The vessel on OCT is just 3. So we feel that we are still okay with 3.0 going high pressure all the way to 26. You want us to take 3.5, 3.5 in both? We could do
That's
that.
what I was thinking about, yes.
Yeah, but 7 2/3 will be almost 5.
50.
I think we look very good on stand boost, which unfortunately you can't see. So
They can see the raw image of the stand
we
boost.
can make a picture and get ready for a final pot. What
Let
is
me ask you, how much room do you have for the final pot regarding the length of the balloon? It's
yes.
for example, 8 millimeters at least, because you didn't go all the way to the ostrom with the LED left main stand.
Yeah. Despite that, we have at least about 10 to 12 millimeter length in the left main available. So we are pretty confident, but we'll check it again when we go in with a 4-5 balloon, please, that we are not hitting the bifurcation where the two stands are already there. It's a very important point that if you do not have enough space, we should skip the final part.
Can you remind us the size of the left main on the
4.5.
OCT, initial OCT? What was the diameter?
4.5.
OCT, yeah, we'll just get that for you.
OCT is
We have to do, we'll do an OCT in the end also. So get ready
And
for
just
the
thinking
OCT.
about I'm just thinking about the, report with 5.0, short 5.0 balloon. Therefore, I asked them.
Okay.
पहले का दिखाना
Gaurav,
है।
can we
पहले का
calculate
दिखाना है।
OCT,
पहले का दिखाना है।
Gaurav?
Yeah.
We need the length of the left main
Yeah.
proximal to the bifurcation. There are many ways to do it. I mean, the way you are doing on OCT is
40,
probably the smartest
40
way to do. But we'll be very careful in the sense we will take
Diameter.
a 4 or 5 balloon, do a stand boost. So this is 4-5 into 8, and we will keep it at the back end. Don't do it.
At this point,
stand boost.
इसको थोड़ा ये करो. You go there.
Gaurav, can you show them the OCT on the screen?
Yeah.
Are you ready?
Maximum जो
Okay,
है
stand
वो,
boost.
बस wait. So the mean diameter as per OCT is 3.34 millimeters.
No, that's a mean. Max is
The maximum is 3.6.
Because you have Onyx 4.0, which can go to 5.75, I think. So you have a room for a 5.0 balloon if you choose to do that for the report.
Yeah, but can you see the OCT on the screen?
Yes.
Yeah, it's a reading as 3.67 is a max. The 3.63 has a maximum diameter.
So can we come back to fluoro? So on fluoro as well as stand boost, we are well away from the two stands at the bifurcation. So we decide to inflate the stent in the left main. Go. How much?
22.
Okay. Yes. So we will take a picture now. Let's go to spider. So hemodynamics are very stable. Ready
Sir,
with
can
contrast.
somebody collect the ACT?
OCT ready, please. Okay, contrast. Small.
Oh, very good.
Okay, we'll do the OCT for you.
Oh,
For
thank you very
for-
much.
for- is the transmission time still there, or
Yeah, we are there, but
Right.
this looks excellent. Perfect
so
result.
you don't want OCT to be shown to you?
No, no,
I
no.
mean, you
No, I don't
Okay.
think we
Go
need,
ahead.
we
Do
don't
it,
need
but
OCT
not required.
section.
Resolute slides.
Okay, those Resolute slides, can we have? We'll have a small, quick presentation on the Resolute. Can it go on a
So-
full screen?
So we are moving to the, because we have only 10 minutes left and we have one presentation, very important presentation by Dr. Jaiswal.
Okay,
Who is,
Thank you so much.
thank you.
thank you very much.
Thank you.
Thank you.
Yes?
Yeah, so you can see this left circumflex to the left main. Can you go back to the first starting point, distal? On the L mode, you can see that there is a overlap of the stents. The apposition which is seen on the transaxial as well as three-dimensional is really good. And here is a left main now. You can see the circumflex LED, and this is a proximal left main which does show part of the cullet, and this is a single layer of the stent what you can see here. All the stents as per the standardization markers, they are well opposed, well dilated, and with a good access to the LED in this particular projection.
Stop at 22 and show, see if you can see the LED,
LED.
mouth. 22.
Yeah, stop here and rotate the axially if you can rotate.
A little bit further
Yeah.
down. Yeah.
Ye-
You can
Go-
see
go-
on the
go.
top LED coming up, looks like.
Yeah, here you can stop. Here you can see the LED. Can you see the LED on the top? On L,
Yes,
L
yes.
mode also.
Come back a
And
little
even
bit.
in the three-dimensional reconstructed
come
mode
back,
also,
Mayur, little
where
bit.
you can see both guide wires separating out, and stent is well opposed. Wait, no, Joel,
Okay.
you keep on continuously moving last 3 runs of.
Let's see the
so
LED run back.
Now you show the LED, OCT of the LED.
OCT of the LED.
And on the left side of the screen, you can see the radiological images also. शेवटचे 3 रन्स दाखवत राहा.
Where can you see there?
Yeah, they are seeing there. So by the time this is booting up,
So actually angiographic images look very good, and we are actually trying to show you the pullback from LED on OCT.
yeah, put a 3D navigation also. Yeah.
So the distal edge dissection is something which one would worry about.
And there is
We
none.
look pretty good here. This was, mind you, slightly big size stent 4.0 when the LED diameter was 3.7. Then we had this question of final case 3535 or 3530. I think the final diameter that we see on circumflex pullback appears to suggest that 30 was quite adequate.
Mayur, come around 20. Sorry, 30. Come around 30. Here you can see the left main circumflex bifurcation. You can see the circumflex on the side. You can keep on rotating there.
Yes, we can see.
Yeah,
Thank you.
here. Okay. So OCT has definitely helped us. And I would like to thank on behalf of the Rubiol Clinic and entire my team, my mentor Dr. Hiremath and the rest of my colleagues for giving us this opportunity, and see you next time. Thank you.
Thank
Thank
you
you
all.
so much for the wonderful case.